So we'll watch a little clip. This will give us a little bit of a segue into what it is we'll be talking about this evening.
Anything. I am the wrong person to have discovered this.
If you don't speak for him, it's still there.
But no one has ever seen. Repetitive head trauma chokes the brain. The NFL does not want to talk to you. Corporation that owns a day of the week.
No proof was presented today because there simply isn't any.
They have to listen to us. This is bigger than they are. What do you think they're doing to you now? That's nothing. You have no idea how bad this could get.
So, as we pull up the slideshow, this will be a talk on concussion, not the movie Concussion, but concussion in a lot of individuals that we all jointly take care of. Concussion being a topic that I'm extremely passionate about. As a neurologist, I see a lot of patients that will come in with concussion symptoms. They'll come in dizzy, confused, thinking's off, ringing in the ears, memory, sleep changes, headaches, a cluster of symptoms that we call post-concussion syndrome. And so concussion patients are patients that I'm quite passionate about providing care to. And that goes all the way from diagnosing concussion, interventions to try and help with concussion, and that whole spectrum. So understanding concussion is the topic of today's talk. We could go to the next slide. That's by way of background. So it's the journey that took me all around the world, brought me from a little country in East Africa called Kenya, where I attended medical school, brought me over to the United States, where I worked as a clinical researcher in the neurology department at Johns Hopkins University. And then that took me through exploring a few passions, became a board certified adult neurologist. And then I felt, hey, let's get a little deeper into understanding things further. Went into a field called neurocritical care, neurointensive care. Neurointensive care is a field of medicine that focuses on providing care to acutely injured patients with neurologic disease. So patients who need to be in the intensive care unit with traumatic brain injury, with bleeds in the brain, with spinal cord trauma and things of that nature, patients that have to be in the ICU. So that was the second part of that long journey of mine that landed me here. The next part of that journey was exploring a field called interventional pain management. And so again, as I cared for patients on the inpatient side, I realized that there were still many gaps in providing full care, and I sought training and board certification in interventional pain management. And then that finally brought me to that final position as an outpatient and inpatient neurologist, focused on taking care of patients with neurologic afflictions, with a host of brain injury associated needs, and conditions such as that. And that's what led to me bringing together an amazing team to set up the Brain, Spine, and Pain Institute. We could go to the next slide. That is not me. We can go to the next slide.
Could have been based on.
Well, so Bennett Omalu, so Dr. Omalu, we can skip that because we've done it. So Dr. Omalu, I give him tremendous credit for shedding light to all of us in concussion diagnostics, and particularly in concussion among athletes. So the NFL. So we had a host of athletes, elite performers, individuals that joined this amazing sport at a really young age. They gave their best years to this sport, to entertaining and performing as elite athletes. What we didn't understand was why longevity, why lifespan was quite shortened in these individuals, and we didn't know why. We didn't understand why these individuals at age 50 would almost look as though they were age 70, cognitively, neuroperformance-wise, and things of that nature. We didn't understand why these individuals had a host of psychological, psychiatric comorbidities. We didn't understand that until Dr. Bennett Omalu really started to look into that, and we came to understand a term called traumatic encephalopathy, or chronic traumatic encephalopathy. So traumatic brain injury induced brain changes. So Dr. Omalu really helped people understand the pathology behind why trauma to the head can have such far-reaching neurological and physiologic and psychological consequences. So give tremendous kudos to him. And then because of that, the NFL, because of the work he did, the NFL has really done a lot to recognize what these young athletes end up exposed to. Recognizes concussion as an actual entity, post-concussion syndrome as an actual syndrome, and now a lot of safeguards in place for these athletes. Not perfect, but certainly now we recognize why. Now, what is a concussion, which is the focus of what we'll be talking about today. So a concussion, it is a force that's delivered to the brain. This force can be in the form of a direct blow to the brain. It could be in the form of acceleration and deceleration to the brain. So acceleration, deceleration, in many of the patients that we all see together, it'll be vehicle against vehicle, jolt back and forth, and that acceleration deceleration is sufficient to cause a concussion force to be delivered to the brain. Now, it's not just that force, not just that acceleration deceleration force, not just that frank trauma to the brain, not just that. It is the physiologic consequences, the brain disturbance that will set in after that index injury to the head. Now, concussion is complex. Concussion is quite complex. It's not just that index event. In fact, it is a cascade, and we'll talk about it. It's a neurometabolic cascade that will follow that index event. It is an endocrine cascade that will follow that event. It is a neurotransmitter cascade that will follow that event. So it's not just that index acceleration, deceleration, or blow to the head. It is a series of downstream consequences of that injury being delivered to the brain. That's what we call concussion, that neurologic dysfunction that will set in after this inciting event. Next slide. Now, this slide is interesting, and interesting because this talks about how for many years we have looked at concussion. I say looked at concussion. Why? When we've defined concussion many times as we well, traumatic brain injury as we define it, you'll see people reference basic elements of this slide. Why do I keep using the past tense? In about mid part of this year, and certainly moving forward, you'll see a slightly different way that we look at traumatic brain injury. So a slightly different way. What do I mean? Right now, if we define concussion or if we define the spectrum of traumatic brain injury, you'll hear us talk about a mild traumatic brain injury. You'll hear talk about a moderate traumatic brain injury, and you'll hear people talk about a severe traumatic brain injury. Now, a lot of controversy related to these definitions came from the fact that if we think about mild traumatic brain injury and we try to conceptualize mild traumatic brain injury, people would conceptualize it the same way we would look at a cold. You've got a mild case of the flu, or you've got a mild cold, or you've got a mild sprain to the ankle, and that's incorrect. In fact, many of the patients or many of the individuals that will present with a brain injury will actually come in with mild traumatic brain injury. Their symptoms are far from mild. They're actually quite significant. They're quite impacting. These are people who months, sometimes years after that index event have new headaches that have taken a life of their own. Months, sometimes years after the index event have cognitive changes that are now new. These are young people who now cannot remember having to write on post-it notes or write on their forearm, like a patient that was describing her cognitive experience to me yesterday. These are patients who, after this index event, as much as we categorize them as mild traumatic brain injury, but now have a new onset of dizziness and balance issues, completely new and now life altering, and a host of other things. So mild is a misnomer. Certainly easy to understand moderate, easy to understand severe, but mild a misnomer. Now, because of that mismatch, a lot of brain injury specialists came together to try and understand: can we recategorize? Can we reevaluate how we look at it? Because mild, which is majority of patients, they're not mildly impacted. They're significantly impacted. In fact, that's who a lot of who we will see. And so I've had it come up many times in many conversations. Well, Dr. Mbeo, it is a mild injury, so it cannot be that bad. And here is an individual who 2 years later has refractory headaches, thinking and memory issues that are completely different, balance issues, and a host of other things, psychological, mental. This is not mild. And so a new way that you will hear people talk about it, I wish it was on my slide, but in subsequent conversations, you'll see me talk about it. A new way that now has us looking at traumatic brain injury, has us looking at these individuals that we previously called mild traumatic brain injury and categorizing them as using a formula. We call that the CBIM. So the clinical presentation, clinically, how do they look? What led up to what's being called a concussion? What are the symptoms? What are the clinical complaints that they're exhibiting? So clinical. Biomarkers, and biomarkers will be big. So B stands for biomarkers, and we'll talk a little bit about this device right over here. So this device that's in my hand. So biomarkers, CB. I stands for imaging. What does their imaging show? What does their MRI show? What does their CT scan show? And what does that tell us about what's going on? And M standing for modifiers. And so now we're looking at patients in a whole different way. So when we talk about modifiers, it is recognizing that people coming into a traumatic brain injury are not all the same. We all have a different pathology, different physiology as we get into a traumatic brain injury. What are these modifiers? It could be psychosocial. It could be biological modifiers. It could be psychiatric comorbidities like depression, anxiety before this injury happened. So the CBIM classification, helping correct for this, what we've been using over these last few years. Not a bad way of looking at it, but then really disparaging in the sense that what we think about as mild is actually majority of who we will see, and they are actually significantly afflicted. So correcting that classification. Now, that being said, for many years we have used the mild, moderate, and severe. If ever we're talking about a severe traumatic brain injury, that's a patient that if Dr. Mbeo is seeing that's a patient who's in the intensive care unit. If Dr. Mbeo is seeing, that's a patient who possibly has loss of consciousness, needing to be in the intensive care unit on breathing support. Their brain imaging in severe traumatic brain injury typically will show us a bleed in the brain or some changes in the brain. And there will very often be post-traumatic memory changes. That's in severe. Moderate is somewhere in between. There will be that index loss of consciousness. There'll be a change in what we call the Glasgow coma scale. There will be changes potentially in imaging, and there will be a shorter duration, but there will be post-traumatic amnesia. And then here we go back to the mild that we've been talking about. Mild being a misnomer. Please, if as we leave this, let's remember mild is a misnomer, and mild does not mean they have mild symptoms, not by a stretch. They have significant symptoms. However, by this classification, loss of consciousness or a neurologic deficit that lasts less than 30 minutes, their Glasgow coma scale, their wakefulness scale at the time of that injury, typically within normal, so that's 13 to 15 or close to normal. Their brain imaging will be normal, and they will have post-traumatic amnesia, but that typically will last a little shorter. So mild, moderate, severe. But leaving this lecture, remember the CBIM classification. That is where medicine is heading. And then that's to take into account that many of these people, so-called mild, have significant lasting injuries that we really need to address. We could go to the next slide. Perfect. So what are the pathophysiologic changes happening in the brain when a traumatic brain injury occurs? You'll hear people talk about damage to axons. So axons are what are right behind your heads as you look behind here. So axons. So that's an image of a neuron, a nerve cell, and the wiring of a neuron is what we call an axon. So damage to axons typically will occur when a traumatic brain injury will occur. There will be a neurotransmitter cascade because it's not just damage to the brain. Neurotransmitters will be thrown off whack. That explains many things. Why do they have sleep changes? Why do they have mood changes? Why do they have heightened anxiety? Why do they have PTSD-like symptoms and things of that nature? So neurotransmitter imbalances and inflammation. And so inflammation, so traumatic brain injury is not just a physical force directed at the brain. Traumatic brain injury also triggers a neuroinflammatory cascade. Why do these patients have a traumatic brain injury and months, sometimes years later, still have symptoms? That neuroinflammatory cascade that gets triggered and really begins to take a life of its own. So think about the physical force, think about damage to axons, damage to neurons, think about neurotransmitters being thrown off whack when all this happens. That really explains the mood and the other physiologic changes or neuropsychologic changes that happen. And then that inflammatory cascade. Interesting to think about because many of our emerging therapies for traumatic brain injury try to address some of these disruptions. We could go to the next slide. Now, you will hear a term. So, what you will hear a term: diffuse axonal injury. Diffuse axonal injury. Now that's a term you'll hear. It'll be in reference to structural changes that will happen in a diffuse manner globally. Why did this bump to the head on the left side of the brain or left side of the head result in diffuse consequences? Why do they not just have symptoms attributable to that bump on the left side of the head? It's because when a traumatic brain injury occurs, many times the changes that will happen or the changes that will manifest in the brain are diffuse. We call that diffuse axonal injury. So injury to the axon processes. Now, an axon, as we think through it, is the cabling that connects many of the things that we have sitting in front of us. So if you think about this mouse that sits on this desk and you look at the cabling that connects it, so if we were to think of what is an axon in this whole process, it's this cabling. So diffuse injury to the cabling that connects neurons. So diffuse axonal injury. Now, many times diffuse axonal injury will be a change that we cannot visualize, except at the microscopic level. Why is that important? It explains why imaging will be negative. The questions come up many times. Dr. Mbeo, how do they have a traumatic brain injury and the CAT scan was negative? The answer is quite straightforward. The answer is it is related to diffuse axonal injury. So it's a diffuse process that's microscopic. You cannot visualize in our conventional imaging. You cannot see it on a CAT scan. There are certain imaging modalities that you can use to visualize diffuse axonal injury. We will talk about that. Conventional MRI, somewhat helpful, but really, really helpful. Diffusion tensor imaging and the newer imaging modalities focused on MRI and focused on revealing this diffuse microscopic disruption of axons. So diffuse axonal injury, that's the explanation again for why is their CAT scan negative, yet they have such florid changes. They're not pretending. It is because these are microscopic changes that are happening in a very diffuse manner and at a microscopic level. We can go to the next slide. Now, what does a concussion patient, a concussed individual, what does a concussed patient come to the brain spine pain clinic or present seeing any of us? What do they come in manifesting with? What are their complaints? And it's a host of things. It's a host of things. And it will spread all the way from physical to cognitive to emotional to sleep related. Sometimes it is all of those. Sometimes it's little bits and pieces of this. Now, physically, many times patients will come in complaining of new onset headache or headaches that have taken their own life. I used to have headaches. Now my headaches are every day and they feel a lot worse than my once a year headache. So increased frequency, increased intensity, change in the quality of headaches. Dizziness. Many times patients will come in saying, well, ever since I had that concussive event, that injury, ever since then, everything just seems off balance. I can't explain it. When I go from sit down to stand up, everything's spinning. When I'm working and I look up, which is a patient I saw yesterday, when I look, just looking up makes me get really off balance, really dizzy. Nausea, sometimes associated with that. Sensitivity to light. Many times these are patients that will be seated in the exam room, either insisting on dimming the lights or in dark glasses because light, it just hurts to sit in light. That triggers headaches. Irritation by loud noises. Vision changes. Vision change is actually quite interesting. So that could be double vision, it could be blurry vision, and many other visual distortions. We've talked about balance changes. Part of this, we'll call it a potpourri. Potpourri? That's what it is. Cognitive symptoms. So cognitive changes. Again, an individual at the peak of their cognitive performance, but noticing that ever since this injury occurred, I now have to write post-it notes for everything. A young lady came in to see us yesterday, and she talks about having to write notes on her hand. And this is previously really high-functioning individual, but now she can't remember anything, and just to remind herself has to write notes on her hand and things of that nature. So cognitive changes. trouble concentrating, trouble with, frank confusion, feeling slowed down, a term that many times they will use, brain fog. It is as though there's something wrapped around my head. I just can't think like I used to think. Emotional symptoms. Many times I welcome, in fact, I always welcome significant other, I welcome family members, I welcome friends if they're available to come in for the visit because they observe the emotional changes. He was a pretty laid back individual. And as soon as the concussion happened, or since the concussion happened, this is somebody else. Things that previously did not anger him or her now easily trigger them to these fits of emotional fluctuations, irritability, heightened anxiety. We forget many times that what leads to this traumatic event is often a life-threatening or a life-changing event. The very same means that they were transported in leading up to the traumatic brain injury is what they still have to use every day. So PTSD becomes an issue. Dr. Mbeo, ever since the accident, it's so difficult to drive. I have to have my friends drive me around. I can't get into a vehicle now. I stay home a lot more. So a lot of emotional lability. Remember, we talked about it. Not only is it that physical force, but we also have disruption of neurotransmitter pathways. So altered mood, depression, anxiety, PTSD for sure, emotional lability. So many other things we see in our patients here. Sleep-related changes. That's actually one of the really common and under-recognized complications or complaints that patients will come in with after traumatic brain injury. I sleep all the time. My sleep is different. I can't fall asleep. I have trouble staying asleep. When I wake up in the morning, I thought I had a good night's sleep. I just do not feel rested anymore. So a lot of sleep-related pathophysiology for many reasons. We could go to the next slide. Now, how do we evaluate concussion in the Brain, Spine, and Pain Institute? How do we look at making this really important diagnosis? How do we evaluate our patients with traumatic brain injury? This flowchart is important, and how we look at our patients quite important. Why? Not only does it help us shed light on this important process, but it also helps us come up with a treatment plan. So the beginning, the cornerstone is a really careful neurologic exam. And I tell my patients, if you're seeing a neurologist and you don't see this thing right here, then you're not seeing a neurologist. Now this is it's not a weapon or anything. So it's a reflex hammer. So it's a reflex hammer. And so as a classically trained neurologist, I find it tremendously valuable to spend time talking to the patient, establishing as detailed as we can of a history. What happened to lead into what we're calling a concussion? What symptoms are you experiencing? What does your neurologic exam look like? So this is a Queen Square reflex hammer, close to my heart because of how facile it is, and a lot of the healthy, good information we can get from it. But it's also a good tool, weapon. So a good neurologic exam to really tell us where are we, what is it we're calling concussion, what is it we're calling this brain injury state, what are the symptomatology that they come in presenting with. Now, after or alongside that really careful neurologic exam becomes blood biomarkers. Let's go back to thinking about CBIM. So CBIM. So let's remember those letters, CBIM. Now that's how moving forward, we will look at concussion. What is the clinical picture? What do the biomarkers show? What does imaging show? And what are the modifying factors in this particular individual coming with a traumatic brain injury? Now, biomarkers are quite important. Biomarkers are a series of blood tests. And simply, if I was to tell you that a tube of blood is enough to help us understand that a concussion happened or did not happen. If I made that statement maybe a year or two ago, that would sound absurd. It would sound almost out of this world. How can you tell what's happening in the brain from a tube of blood? But it's reality, and it is here today. Now, biomarkers or blood markers for a concussion actually found use in the military. What do I mean? think about it, when exposed to the field of combat, there are no neurologists following around with reflex hammers. There are no neurosurgeons following around close. Maybe there are some, but in specialized hospitals. But then decisions need to be made really fast, really, really fast decisions about, was that blast injury enough to cause a concussion? Was that Humvee rollover enough to cause a concussion, and enough for us to say, well, let's pull out and let's go seek a higher level of medical care, and things of that nature. So these decisions had to be made, and so almost a decade ago, in the military, biomarkers started to find a place, and biomarkers are blood tests, and a device that came from that. So a device that came from that dive into trying to understand concussion or not in the military population is this device in my hand right here. So the Abbott Alinity device, so a handheld device, which certainly a CT scanner cannot travel through combat, but a device such as this certainly can. So we'll make it smaller. So a device such as this can. Now, using this device and using a drop of blood, one is able to measure certain what we call biomarkers, certain biomarkers of neuronal injury. We'll talk a little bit about them, but these are proteins that live inside neurons. When neurons get injured, these proteins spill into the bloodstream, and we're able to detect them. Now, we've taken away the issue of no neurologist in the field or no neurosurgeon in the field, and we're able to diagnose concussion with a device as simple as this. So biomarkers. So for years, it lived in the military, and recently was FDA approved for use in a non-military setting. Still acute, still early, but listen to biomarkers, and certainly listen close, because this is going to be a really integral part of how we diagnose concussion. And we use that at the Brain, Spine, and Pain Institute. Neurocognitive testing. So that is a huge part of trying to understand what is going on in this manifestation of concussion. Neurocognitive testing, memory testing. So patients will come in complaining of different memory phenomena. I used to be at the top of my mental game. I did not have to work hard to think, to do the things I do. Now I work so much harder. Neurocognitive testing. How do we explain that? How do we measure that? How do we quantify that? And so at the Brain, Spine, Pain Institute, what we do is we will run a series of neurocognitive tests. And we'll talk a little bit more about that. But again, part of our diagnostic protocol includes neurocognitive testing. Vestibulo-ocular testing. What is that? That is eye movement testing. Think about that concussed athlete, so who unfortunately finds themselves on the other end of a boxing glove, and once we establish that they're breathing and their heart is beating appropriately, you will see somebody at the ringside who thinks they have a concussion, holding a device or holding their finger and trying to get them to track with their eyes. That's vestibulo-ocular testing. But in a much more sensitive way, at the Brain, Spine, and Pain Institute, we use much more specialized tools. At the bedside, as a neurologist, we will do that. We will do the eye movement test. But then we use other devices for very sensitive eye movement evaluations. Concussions affect the eye movement pathways. And so using very sensitive tools, we're able to help shed some light on the consequences of a concussion using this test called vestibulo-ocular testing. Not only that, so it helps a lot to understand that. It helps a lot to explain certain symptoms that patients come in with. My vision's blurry. My eyeglass prescription feels like it changed. I have headaches every day. I have brain fog or visual fog and things of that nature. I'm sensitive to movement. It's so uncomfortable to drive in the car nowadays. So vestibulo-ocular testing really helps us understand that. But it also helps us come up with how do we help treat these concussion symptoms. Vestibular testing, again, on a similar note. So at the Brain, Spine, Pain Institute, really important to us in evaluating our concussion patients to perform vestibular testing, balance testing. As a neurologist at the bedside, vestibular testing or balance testing, that involves stand up, put your feet together, hold your arms out, and close your eyes. Another way we will assess it is walk like you're walking a tightrope. And so that's one form of vestibular testing. You might see, stand on one leg and let's see how steady you are. That's a form of vestibular testing. Way more sensitive, and you will see that in today's tour as we walk through the clinic, is computerized dynamic posturography, CDP. balance assessment, but then in a much more objective manner, in a way that we're able to objectively show deficits, in a way that we're able to quantify and then come up with a treatment protocol to help in this patient that now has balance issues after the concussion. In our protocol, we always include neuroimaging. So quite important to think about neuroimaging. What do we mean when we talk about neuroimaging? Now, we will talk about special, a CT scan at the beginning, which many times in the patients that I will evaluate in the clinic, many times is negative. If it is positive, there are certain reasons why, and they will fall into that cluster of moderate to severe traumatic brain injury. But then a little deeper than regular CT scan is an MRI scan, and a little deeper is a special MRI scan called a DTI MRI. So that's part of our protocol. So we can move to the next slide. Now, we've already talked about the importance of an in-depth neurologic exam, an in-depth conversation with the patient, an in-depth, an amount of time spent really understanding, quantifying, detecting, documenting neurologic deficits. So really important and cornerstone to our process is that neurologic history and neurologic exam. We could go to the next slide. Concussion blood biomarkers, we did talk about that, and we've talked about in 2025 moving forward. Do know this device. This is the iStat Alinity device, so a bedside portable device that one is able to use to detect from the blood biomarkers of concussion. There are much more specialized ways of doing the same thing, and we look at other blood biomarkers, but then certainly keep in the back of your mind, remember, blood biomarkers are going to be quite important in 2025 moving forward in making this important diagnosis and objectively demonstrating this diagnosis. Some of the biomarkers we talked about, these are, like we said, these are proteins that live inside neurons. When neurons are injured, they spill into the bloodstream. S100B, GFAP, UCHL1, neurofilament, and we will say neurofilament has certain subsets to it, neurofilament light chain and neurofilament heavy chain, and sometimes we'll look at just the neurofilament level. So a lot of proteins that tell us about the structural integrity of neurons. So concussion happens, blood biomarkers spill into the bloodstream, we're able to detect that. How is that possible? If you imagine, if any of us at this moment noted that they had left-sided chest pain, if we went to the emergency room, standard of care will warrant that there will be a blood test done, a blood draw. Why are we drawing a vial of blood when the complaint is pain on the left side of the chest? We are measuring biomarkers, blood biomarkers that are elevated because cardiac cells have been injured. Similarly, we realized a few years ago, as we talked about, that we could measure biomarkers, markers in the blood, signaling injury to neurons. So blood biomarkers. It's an evolving story, but really cornerstone in part of us, our ability to objectively diagnose concussion, especially at the Brain Spine Pain Institute. This is something big that we do. Neurocognitive testing we talked about. So again, just talking about objectively evaluating these cognitive consequences of a traumatic brain injury at the superficial level. You will see computer administered tests at the Brain Spine Pain Institute. There's a standard battery that we utilize, again, to objectively quantify these memory complaints that patients will come in with. Sometimes that'll trigger us to go a lot deeper and to bring on a neuropsychologist for a much deeper dive. The computer battery typically will take an hour, maybe an hour and a half. The neuropsychological testing, if that becomes triggered, would take about a day. But really helpful in understanding the consequences of the injury, understanding the cognitive complaints that patients face, but also helpful in helping us determine where do we go from here with regards to therapy. Next slide. We've talked about vestibular and vestibulo-ocular testing. Again, remember that athlete who unfortunately finds himself on the other end of a boxing glove and at the ringside, follow my finger with your eye. And certain tools that we use in a much more sensitive way to measure these movements will be what we call vestibulo-ocular testing. And so we look at certain eye tracking movements. We look at certain movements. We talk about smooth pursuits. We talk about saccades. We talk about fixations, that ability to fixate on a target, many times which gets disrupted when a concussion occurs. So really important that we assess, but it also helps us come up with how do we treat these deficits that arise from a concussion. Computerized dynamic posturography, balance testing. We've talked about balance testing. And again, many of the patients that will come in after a concussion talking about balance issues. When I go from laying down to sitting up, the room is spinning. When I go from sit to stand up, I almost fall. I've had multiple falls. Look at all the bruises I have, doctor. Computerized dynamic posturography, a really sensitive replicable way that we can objectively show what balance deficits have arisen resulting from a concussion. And not only that, quite useful in our setting because it helps us come up with a treatment protocol to try and help recalibrate this disrupted balance pathway in the brain. So CDP, computerized posturography. And we talked about neuroimaging. Many times patients that will come to see me at the Brain Spine Pain Institute as a neurologist will come in having had an evaluation in the emergency room. They will correctly have had a CT scan done. And that reason I say correctly is because a CT scan is an imaging modality that we use to screen for certain pathology. What do I mean? We are trying to make a really quick decision. Is there or is there not a bleed? Is there or is there not major damage to the brain? And certainly bleeding becomes part of that. And really fast to acquire, we're talking minutes. It's present in most emergency rooms around the country, so easy to implement as a screening tool. It never surprises me when that CT scan is negative. In fact, I am happy. It does not rule out a traumatic brain injury. It just tells us there's no bleeding in the brain, hence not a moderate to severe traumatic brain injury by our previous classification. So they'll have had a CT scan. I'm okay with that. And many times, as we talked about, the comment will be, Dr. Mbeo, my CT scan was negative. How then do you say that I have a traumatic brain injury? How then do you say that I have a concussion? Many times that CT scan will be negative, and that's what I tell my patients. Now, in order to visualize the damage that has occurred, the damage that the brain has suffered, in order to visualize a much more sensitive way, a much more amplified way of looking at the brain is required, and that is an MRI scan. Now, not just a regular MRI scan. There's value in that, and then many times that's what we have available as a tool, and we will interpret it if that's all we have. But what we must think about in 2025 and moving forward is what's called a diffusion tensor imaging. So DTI. Now that's we'll call it a filter that's applied to certain MRIs. So a filter that's applied to help us very carefully, very in a very sensitive way, visualize tracts, pathways in the brain that have been disrupted. They many times will help us visualize what we talked about a few slides ago, diffuse axonal injury. This diffuse process that previous to our ability to perform DTI, previous to that, was only microscopic. It still is microscopic, but we could only visualize it on a microscopic level. Now, a DTI MRI is quite helpful in visualizing this previously invisible injury to the brain. So whenever we think about MRIs at the Brain Spine Pain Institute, and whenever we are thinking about using that as a modality for understanding what has happened to the brain in a traumatic brain injury, DTI is quite an important part of that diagnostic arsenal. So not all patients, but carefully selected patients. Along with that, we also try to understand, are there microbleeds? Are there tiny little bleeds, what we call microbleeds in the brain? Again, on regular CT scan, would be almost invisible. But then with a DTI and an SWI, protocol MRI, we're able to visualize these tiny little blood products that previously were invisible to us. So now, with these sensitive imaging techniques, what was previously invisible now is visible. What previously we could not explain, now we can explain. So DTI, MRI, that's a cornerstone in our imaging protocol in the patients that we bring in for concussion evaluation. Now, important that as we evaluate our patients, especially at the Brain Spine Pain Institute, when we evaluate our patients with a traumatic brain injury, it's not lost to us that this injury is rarely an isolated injury. What do I mean? It is rarely an injury that only affects the brain. Remember, what connects the brain to the rest of our body is really a dinky structure we call the cervical spine. And so many times these patients that will come in with a traumatic brain injury will have attendant injury to the cervical spine. So again, think about it. The connection of this giant bowling ball to the rest of our body is this thin structure, the cervical spine. And so with that whiplash, with that injury that the body gets subjected to, that acceleration, deceleration, that direct blow to the brain, many times there is an impact to the cervical spine. So really important in evaluating our patients that have come in with a traumatic brain injury is carrying out a really sensitive and really objective examination of the spine, the cervical spine, and the other elements of the spine. So, really, careful examination of the spine becomes important. And that examination begins at the bedside. So, what is your bedside range of motion? What is there any tenderness in any areas to the touch in areas of the spine that we can elicit? But even more important and even more accurate and even more objective are some of the tools that we use on the physical therapy side. I would love for those of you present to spend some time looking at those tools. Really important, really accurate, really objective tools that we're able to use to not only assess but quantify, compare, and then protocolize the treatment of these patients. So, really important to us is not just an assessment of what is happening in the brain, but certainly an assessment of what's happening in the spine. Many times, the symptoms that patients with a traumatic brain injury will be experiencing, many of those symptoms can be attributed to changes they're experiencing in the spine. So, important to us to not only assess the brain, but also to assess the spine. And we use a lot of tools. We have a lot of expertise, which we're proud to show that to you in the next few minutes. We could go to the next slide. Now, as we talk about just one aspect of helping, the question comes many times, Dr. Mbeo, fine, it's I'm glad that we have some closure on what I'm suffering. I'm glad that we know that I have a traumatic brain injury. I'm glad that we can show it using objective tests. What can we do about it? And so when we talk about what can we do about it, that's why we typically will go through that really carefully calibrated set of steps to make a diagnosis. But the reason we do that is to come up with why and how. How. And so when we talk about therapy that's focused on helping the brain heal after a traumatic brain injury, cornerstone to that is going to be really skilled vestibular therapy. What does that mean? Again, this traumatic brain injury many times will result in changes in balance, feelings of imbalance, different vestibular complaints that these patients will experience. And using tools that will help us address this will be quite key. Again, for those of us who are in-house, I offer it with a lot of pride to have you walk through the clinic to see the tools that we use for the complex vestibular therapy that we offer our patients. Now, so actually, we could probably, so, and we talk about vestibular therapy, we talk about, again, maneuvers to try and help recalibrate the balance systems, exercises to try and help habituate, improve balance, improve coordination, exercises to improve the sensitivity to motion that many of these patients will experience, exercises to help improve the vestibulo-ocular, the eye movement dysfunction that many times set in. And it'll be a combination of that. And not only that, really important that we address not just the neurologic, but also the physical, so the musculoskeletal symptoms that they come in with. So this is just one corner, one part of how we address rehabilitation. Many other tools I would love to show you, and we will look at that when we have our walk through the clinic. We could go to the next slide. Oh, well, that brings us to the end of the slideshow. Now, it brings us to the end of the formal talk part of the presentation. It actually begins a few steps that we will take over to the physical therapy side, where we will show a lot of these tools, where we will show a lot of how we assess and address concussion-related changes. Hopefully, in a very wordy way, we've been able to try and understand the traumatic brain injury, the consequences of it, the pathway that we would take to make a diagnosis of it, the importance of knowing that it exists, and then, really important, how do we fix it? So we'll talk about that in the next few steps.